On this episode of the Athletic Potential Podcast, we'll be discussing knee pain and ways you can get rid of it. Welcome to the Athletic Potential Podcast, your place to come and get answers to your athletic development questions. We cover a range of topics, all related to helping you to achieve your athletic goals so that you can experience and enjoy the athletic career that you deserve. I am your host, Dr. Mike Matthews. Hey everybody, and welcome to the Athletic Potential Podcast. Excited that you're here with us today. This is episode 61, and we're going to go back to our traditional format of discussing some questions that were sent in. Actually, what will likely happen today is we have two very related questions, and so I've grouped them together. And a lot of when I answer these questions, I think we'll be able to answer them simultaneously. So that being said, I'll read one question, then we'll get into it. And then the second question will bring up an additional concept, which I think will be helpful for everybody to hear. So we'll get right to it. Our first question comes from Melanie. Melanie states, I am a older overhead athlete volleyball player that's been playing for at least 4 years beyond the collegiate realm. I am attempting to stay healthy enough to be able to jump and hit even going into older ages, but I have come up with a meniscus injury that I have been unable to get out of pain with. What is your opinion of meniscal surgeries, and or do you feel like if I have a meniscus tear I can rehab out of it? All right, Melanie, this is a fairly in-depth question. And a lot of the times I typically take these questions and I answer them individually. And the reason for that is because it's a very specific answer for Melanie. But this question, I not only answer specifically, but I also feel like it would be a benefit for everyone to hear. So what we're going to talk about today, and we'll get into the meniscus here in a minute, but one of the overarching concepts I really want to start with is first and foremost to know that when it comes to us talking about injury and recovering from injury, it is of my opinion that it is vital to know what structures we are dealing with that may be injured or insufficient and how we can affect them. We meaning me as a rehab specialist, the client, and or other medical professionals, how we can affect those tissues to allow them to heal back to their normal structure. And you're gonna hear me talk a lot about normal structure, normal anatomy, abnormal anatomy, and these things are very key concepts to talk about. And so let's talk about the meniscus. For those that don't know anatomy a whole lot, which is totally fine, the meniscus, there's two of them that exist inside of the knee. And there's a medial, which is on the inside of the knee, and there's a lateral, which is on the outside of the knee. I want you to picture just two bones coming together. What you're going to have is two very disc-looking shaped pieces of tissue that are essentially like, this is not true. So everybody in the rehab realm and the medical realm, I get this is not true, but they equate to like a very rubbery substance. Something that will take a little bit of shock, but it's got a little bit of give to it, but not very much give to it. And their entire existence is to do a couple different things. And one of those things is to create a shock absorber inside of the knee. There was an interesting study, and I'm going to go definitely on the nerd mode on this podcast a little bit because I feel like some of these studies are worth mentioning because they teach us a little bit, not only what the structures of the knee do, specifically in meniscus, but also how we can help rehab them. And I think it'll give everybody a little bit better understanding. So without getting too far in the weeds with this, there's an interesting study back in the, I want to say 60s and 70s, although I may be wrong, and I apologize for not vetting this, but there were reports of people going into doctors saying, I have this knee pain. They discovered that they have a meniscal tear, and the docs or whatever medical specialty at the time thought that the meniscus in the knee was kind of like an anatomically dead structure. This is like the appendix in our digestional tract. This is, there's a few of these things that exist in our bodies that, that just maybe don't seem to have a whole lot of purpose. But there was a hypothesis that this meniscus was one of these anatomically dead structures, and it was at that point was painful. And they said, you know what? I don't think this is actually needed in the knee. It hurts. Let's just take this thing out. It'll get rid of the pain and we won't have to worry about this anymore. And so what they were doing these very large meniscectomies. And meniscectomy just means cutting of the meniscus out. And they were doing these very large surgeries, taking the meniscus out, or large chunks of the meniscus out. And they're thinking, oh, it's okay, great. And these clients actually did okay for a little bit with little to no pain. But what then they found out was in a relatively short time period, it was still years, but in a relatively short time period, the majority of these clients ended up with significant joint arthritis. So they just beat the crap out of their cartilage to the point where it just withered away and was gone. And it's an interesting case study in the sense that you look at these people that don't really have a functioning meniscus or either meniscus because they've been removed and taken out, and all of a sudden the majority of them develop osteoarthritis. So obviously that's indicating that the meniscus is providing some sort of support, stability, and shock absorption to the knee, and is protecting the cartilage. So we know that we need meniscus. We know we need a meniscus or menisci, right? We need both of them to preserve our knee. So Melanie, coming back around to kind of what you're talking about, when somebody asks me like, hey, I've got a meniscal tear, I first and foremost ask them like, hey, have you had an MRI and have you talked to a doctor? And then in my case, it's always, tell me, can you move your knee? Can you extend your knee all the way straight? Can you bend it? Now, Melanie, I'm assuming you can extend it and bend it because you're talking about still playing volleyball. So I'm assuming you can. If you cannot, if your knee is locked, which that does happen after a meniscal injury sometimes, is if your knee becomes very locked and you can't bend it or extend it to certain degrees of motion without just getting stuck, those things are a big deal. You got to go get that taken care of. That is typically a surgical case. Anybody that comes into our facility that has those type of symptoms, I typically send them for an MRI and get the consult with a surgeon already going. And that is because there's likelihood is that tissue has been bound up or something's going on that's limiting the mobility of the knee, and it's just not something that's we can work around for very long. So, but assuming you have good range of motion in the knee, there's two main surgeries that happen, and I'm going to be referencing a study that was done a while ago, and it was more of an editorial piece by a couple different authors and doctors, and they were just talking about, hey, like, should we in surgery take these meniscal tears, and should we just, cut part of them off that are torn, take them out? They call that a meniscectomy. Okay. And should we do that, or should we try to preserve them and repair them? Repair them looks like you sew them back together and put them back where they're supposed to be. And a lot of people are kind of like, well, why wouldn't you just repair it? That's like, a really good idea. And the idea behind that is sometimes they work and sometimes those surgeries don't. And then the amount of time that it takes to be able to repair or to recover after repair is a lot longer. And so just to kind of give everybody an idea, it's let's see, and I've got a couple notes here, and I apologize. Sometimes my ability to organize my notes is not so good. So it's going to take me a second to find a couple different things here, but let's see. On average, and this is more geared towards sport, which is good. So a return to sport after meniscal repair typically takes 4 to 6 months, whereas a meniscectomy is as low as 6 weeks. So, I mean, that's a big difference, right? And so, yeah, a lot of people are like, well, just take it out and I'm going to get back to play. And the pain will be going to be good. But the problem is what we find is that those clients that take the meniscus out, they have a significant risk of developing cartilage wear, up to 3 times as much cartilage wear in someone who'd had a meniscal repair. So, Melanie, let's get kind of more straight into what we're talking about here for you. And that is when we talk about your meniscus and what you should be able to do and what, you're trying to do, you're trying to jump, you're trying to land, you're trying to, cut and pivot, sometimes dive, right? In regards to volleyball. And I'm no volleyball expert, but I also don't know what position you play in volleyball. I'm assuming you're running and jumping and hitting, because you kind of mentioned that. So we'll just say that you're an outside hitter. And if that's the case, you got to look at the meniscal functions. The meniscus functions, it transmits load. It is a huge shock absorber in the knee. Okay. It provides stability, and it helps with proprioception to a certain degree. Now, you need all of those to be able to do what you just said you want to be able to do. Now, if you have a massive tear in your meniscus, that's going to limit your ability to do that. Okay. But at the same time, you're going to want to preserve as much as you can because you have the high impact of jumping and landing. So right off the bat, I can tell you, you come in and you talk to me and you talk to me about your condition, and assuming your knees bending back and forth and you have a substantial meniscus tear, and I don't know your age, putting your age, but you did say something, after collegiate. So I'm assuming we're 4 years probably past we're 4 years past high school. So we're in the 20s, you're mid 20s. So maybe we're in the mid to late 20s, maybe early 30s. I can tell you right now, if your meniscus can be repaired, I would repair it. And the reason is because if you want to continue with volleyball, you're going to need to be able to take those impact forces, okay? A lot more than, say, somebody who's just, more worried about walking or golf or less impact type sports, okay? Just so you know, a lot of times people will say, well, sometimes those repairs, they don't do as well in regards to sport, returning to sport. But based on the study I've already referenced, 86 to 91% will return to sport in 4 to 6 months. 86 to 91%. These are good odds, okay? And I'd argue that I always look at these and say, look, and that's assuming you have, good rehab. We don't know what everybody had in these studies, or if they had good rehab or not. Were they really, strong, be going in or not? There's a lot of factors that may increase your ability to be one of those, the 91% that return to sport. So, Melanie, based on what you've just said, I definitely would consider the meniscus repair. Now, I will say this in full disclosure, I don't know anything about it. Take my advice for a high grain of salt. This is not official medical advice. This is just generalized, me talking over a case. We can call it a case study of any sort. And anybody listening to this is not telling you to go get a meniscus repair. My sole purpose of this discussion as of right now is to know the differences between a meniscus repair and a meniscectomy, where they'll take part of your meniscus out, so that if anybody's in these situations, or if you have knee pain and are told that you have a meniscus, that you have a little bit more idea and knowledge about what the potential surgical techniques are. And I will also say, I'm not a surgeon, so I would absolutely say you need to go consult a surgeon before you do anything else in regards to talking about surgeries. I will tell you this, that in my experience, when I'm trying to rehab those that have meniscus tears, documented meniscus tears with MRI, what I have found is that we've had, and I'm going to just kind of guess because I don't have it written down, and I apologize for this, but I'd honestly say we probably have about a 70% to 80% success rate in rehabbing our clients back to their chosen level of sport. This is assuming this is not a massive tear that's limiting mobility in the knee, and it's not a massive tear that may not be limiting mobility in the knee. The bigger the tear, the bigger the issue you're going to have in getting back. In regards to moderate to mild tears in the meniscus, we've seen pretty good results getting clients back to sport without any surgery. So, Melanie, I hope this kind of answers your question a little bit, but I just want everybody to know, when we talk about meniscus and we hear a lot about it, there's a lot of things that you hear, but unfortunately, maybe kind of convolute what the meniscus do and why it's important that you have it. And then if you have pain, what you should do about it. Okay. So what I tell everybody is, look, when we talk about meniscus injuries or problems, first and foremost, we need to know the size of the tear. If you don't know the size of the tear, it's probably not a bad idea to go figure out what the size of the tear is. If it's inconclusive, we're going to just assume that it's small, and then I would go after rehab. If it is a moderate tear, then you're still going to try rehab for 4 to 6 weeks. Rehab looks like physical therapy. You go in, you do exercise, mobility work, all of these things that will help you. After 4 to 6 weeks, your knee pain continues and you're unable to return to sport, you're typically already getting a surgical consult just to talk to a surgeon to see if this is even something that may be a surgical case, and then they can give you additional options beyond what beyond which I even know. So just know that in regards to the meniscus. Okay. Another thing that I want to cover right now, and this is a general concept outside of just meniscus, is we talk about meniscus, and we had that interesting case study where they were pulling meniscus out of people's knees, and all of a sudden they develop osteoarthritis and cartilage wear that's substantial. They didn't even talk about the instability part of their knee, but they had unstable knees too. But when it comes down to this, and a lot of times when we're talking about getting back to your sport with whatever injury it is, the tissue that is injured or damaged, we need to know what tissue it is, how bad the damage is, and that'll kind of give us an idea of whether or not you're going to have a more successful likelihood of outcome in regards to non-surgical techniques. And I always tell my clients, I tell my students this, look, structure dictates function, okay? And then function influences structure. And this is kind of like a general concept that we teach, and that is, your body is built to move, your body is built to handle stresses, and then it's the specific stresses of your sport on the structures of your body that will either build them up, wear them down, those type of things. And typically when clients come in and they're complaining of shoulder pain, hip pain, knee pain, whatever it is, we look at it and say, okay, well, the structure that's involved here is a tendon. Your tendon is meant to take load in these positions. Currently, your tendon is not at the level it needs to be successful. We need to build the tendon back, meaning help the body to build the tendon to make it more robust and strong to take the stress. If it's cartilage in the knee or the shoulder, how do we influence cartilage to get it to heal or to get it to improve enough to be able to return to sport? And that's why I always say, like, it really matters what structure we're talking about, because it will absolutely change the game in regards to how we're going to treat it. If you have, say somebody comes in and they have lack of shoulder mobility because they have shoulder pain, a lot of the times what we'll hear is people say, hey, look, we're just going to work on your shoulder mobility. And I think when we get your shoulder mobility back, we'll make sure your strength's good. And if that's the case, okay, great. Then I think we'll be good and we'll get you back. And to me, and I feel like we're missing, and those things are good. Those things are good. It's impairment-based treatment, which isn't a bad thing. And a lot of schools of thought will use that. And it does get results. I will admit it does get results. However, I don't think the results are as good as if we know what structures we're dealing with to provide those structures the best environment for healing, give them time to heal, and then load them up again in the proper way and progress them back to whatever activity that is, if it's sport or whatever. Those are where we have found here at Athletic Potential, those are our best outcomes, is when we understand that structure dictates function and function influences structure. And if we can get that relationship to talk to each other in the right way, then we optimize structure, which then optimize functioning, which then equates to highest level of performance on the field of play. So a little bit of a rant, but also kind of just more of an educational thing where it is very important that we know what structure we're dealing with. And again, this is my opinion. And I know there are people that disagree with me on this, and that is totally fine. I love conversations like this. But I have found the most success when I have been able to identify the structure that is the problem or damaged or insufficient, and we've been able to influence healing in a way that allows it to get back to closest as possible to normal, to load it back up appropriately over time, and then to get people back to sport. So I'll say it one more time just to kind of emphasize the point, and we're going to go into this in the second question a little bit more in depth, and that is structure dictates function and function influences structure. And if you understand that, then you'll be able to work through some of the issues and knee pain that we're going to talk about. Now, let's transition into a second question, and it's going to bring up probably one of my all-time favorite studies that I've ever read in the research. I find it fascinating. I think, and the story is kind of fun to hear, and I mentioned it on the podcast before, so sorry if you already heard this, but it's kind of fun to talk about. And let's do this. So I'm going to get ahead of myself. Let's look at the question, and then we'll go from there. This is a physical therapist that's writing in, okay, and so they're asking me a little bit more of a clinical question, but I think it's probably worth listening to. So let me look here. Let me pull it up. I apologize. Some days I work better with technology than others. Today, we're a little all over the place. So, here we go. Kevin asks, hey, I'm a physical therapist. I've been practicing for 2 to 3 years, and I'm having issues correctly identifying what structures, yeah, we just talked about this, what structure in the knee itself is injured when testing for ligaments, meniscus, cartilage. Do you have any insight or what is your evaluative system that you use that helps you identify what structures are involved to therefore then provide the best treatment? Kevin, this is a great question, and this is the question. This is the reason why a correct diagnosis, and I'll just say this, and I know the word diagnosis can go a lot of different ways, and there are parts and there are states in all over that have limitations on if PTs are able to diagnose or not. So I'm not saying I'm diagnosing these things. What I'm saying is, based on a diagnosis of whatever it is, then we would treat things a certain way. So let's talk about this. And I'm going to pull up a study for those that are watching the video. You'll see me look away here for a second. I'm going to pull this study up, but let's talk about this. So one of the things that we as rehab specialists do and physical therapists do is that we need to identify, just like we said, we need to identify the structures that are injured or insufficient or have some sort of damage or limitation to them, because therefore then we can provide the best environment for healing and then appropriately load them over time. The knee can be a very tricky joint to test for. And I know it's a conversation I've had with multiple students over time. And that is, it's interesting because they'll be like, oh, it's a knee joint. It's a hinge joint. It moves two ways, right? And there's a really good test for the ACL. There's a really good test for the MCL, and the LCL doesn't get injured as much, but there's a good test there. And meniscus, there's this cluster test. So I got the knee figured out. And then my favorite part is we'll go into these knee exams and my students will put somebody through the knee exam. They'll be like, I actually don't know what it is. You know what I mean? And I'm like, well, you have all your good tests. Did you test them all? And they're like, yeah, but he's got pain here, or there, or no, there's no pain on this one. It can get very convoluted. I had the same issue as a clinician, and it was frustrating to me that I thought I had all this figured out and I didn't. And then I realized that that's because symptoms or what the client feels is not always the same. And that is because different structures create a different type of stimulus or sensitivity or a sensation than others. So, and I found this study with the help of a mentor of mine, but he kind of threw me the study. He's like, look, this thing is awesome. Like nobody's doing this. And this was a while ago. It was 10 years ago that I talked about it in the studies from the 90s, so late 90s, I believe. But I'll tell you the story. So what happened is there were two orthopedic surgeons. I don't know where they were, and I apologize if they're listening, or if you ever heard of this podcast and you're like, oh man, you botched this thing. I'm going to tell the story as best as I've heard it. There's two orthopedic surgeons. One of these orthopedic surgeons was having significant knee pain. He went and got an MRI. He saw something on the MRI and he's like, dude, I think I've got this, but there's something over here too. And he's like, but it doesn't feel right. It just feels weird. Like there's pain, but I would expect the pain to be over here. And then and I'm going to dramatize this a little bit and characterize it just a little bit, because I don't know what they said to each other, but it just kind of would seem like if they're nerds like I am. But basically one guy goes, well, I know how to do that surgery. You know what you can feel it, What if we did this where I went in with a scope, where they just put scopes in and have a camera and then they fix things arthroscopically. But he's like, what if I went in with a scope, but we didn't put you out? We didn't put you under anesthesia at all. We just gave you a local anesthetic right where the incisions are going to be, but everything else in the knee, you're going to be able to feel. And we'll go around and we're going to take a probe and we're just going to poke all the structures of the knee, and you're going to tell me how it feels, And I'm like, dang. And he agreed. He's like, yeah, let's do it. That sounds like a cool thing. And they call it neural sensory mapping. Okay. And the study was done in 1998, and they wanted to know what each structure in the knee felt like, but really which one produced pain. Right. And so this is what they did. They went into surgery. And the one surgeon who's getting the surgery done on his knee is awake, and the other surgeon is, ready to go. And they put the scopes in and they start poking everything, and they start trying to figure out what hurts, what doesn't, what feels weird, what doesn't feel weird. And they were able to, grade it out and be like, 0 is no feeling, 4 or a 3 is like significant pain, and then stuff in between, right? So interesting stuff. So let me just get here. And this, again, ties into what we've already talked about in regards to that structure dictates function, okay? And function influences structure. And right away there, I'm like, okay, well, in my head, I'm like, before I read the study, I was like, all right, here's what's going to hurt the most. Cartilage is going to hurt the most. If there's anything with the cartilage, we're going to feel it. Like, it's just not going to feel good. They're going to hit the ACL like right in the middle, and it's going to be like, oh, that doesn't feel good. I don't like that. And they're going to rub up on the meniscus and it's going to hurt, right? And those things aren't going to be bad. And these other structures, maybe some like a capsule, and there's a fat pad in the knee, and Some of the other structures, it won't really give them that much, right? And this is based on experience that I've had and thinking that I knew. Well, comes to find out that they're in there probing around on the cartilage and there was zero feeling. Healthy cartilage produced no pain and almost no feeling. And that was interesting. It was like a feeling of pressure is what they talked about. And so I was like, well, I'm wrong on that one, right? And then I was like, well, what about the ligaments? Well, interesting. They flicked the middle of the ACL right in the middle and didn't localize with pain. It was like a 1, mild pain. It was like, yeah, I feel something like, oh, it's kind of weird and uncomfortable, but not a big deal. But if they poked where the ACL attached at the top or the bottom, higher amounts of pain. So interesting things. You hear this where people will be like, oh, I cut and boom, I felt something pop in my knee. But I was like, dude, something's weird. It doesn't really hurt. And then you go in and you look at it and it's like, well, the ACL ruptured right in the middle. And since the ACL ruptured right in the middle, they didn't feel it as much. But then you've got other guys, it's like, dude, I hit my ACL. It was nasty. Oh, well, they go in them and they look at those knees and it's like, well, it's right where it attached on the bottom, And it doesn't always happen that cleanly and those kind of things, but it was interesting that they found that. Now, I was always then curious. I'm like, okay, cool. What is the most pain-producing structure in the knee? And I never would have guessed. It was the fat pad in part of the capsule, but it was really the fat pad, the thing that produced the most pain when they poked it, the fat pad of the knee. And if those don't know what the fat pad is, it's right underneath your kneecap. When you stand, it's like the little pouch looking thing. Its main job is to provide buffering and insulation against tendons, against each other in the bone, as well as if you kneel down, it gives you a little bit of insulation and padding. All right. But that was the most like painful part, of the whole knee exam. Now, interesting enough, they went and they found out what was producing this surgeon's knee pain. He had a hole in the cartilage. I think of like a pothole in a road, but he had a hole in his cartilage. But when they hit the cartilage just to the outside of the pothole, no sensation, no pain. They hit the middle of the cartilage, like right in the middle of the pothole, pain. Like on a 3, no, not 3, it was a 2 or something on that. And I should look it up, but it was like a 2. Okay. But it was interesting stuff. And I'm bringing it back in now and I'm talking to you, Kevin. What I did is I took this study and I said, we know what tissue types those things are, but when I test for things now, say I'm testing for an ACL and I'm using that Lockman, right? And I look at it and I pull on it and I feel like it's given me a lot of range of motion when it shouldn't, and the client then experiences pain and he's like, oh, that hurts. Like right here, it hurts. In my head, I go, well, you can have an ACL sprain, but it wouldn't hurt. If this thing was completely dislodged and torn, it probably wouldn't hurt, right? I mean, because you're not pulling on the ends anymore. It doesn't hurt because you're not pulling on the ends. But if it's a slight tear or a moderate tear, but it still has connection, you yank on it, depending on where the tear is, they may produce pain. And so there's that. In regards to the meniscus, like you got to put the pressure on the right parts of the meniscus to produce the pain. They found that you can if they have an issue, probing around the meniscus was not the same all the way around the meniscus. It wasn't the same on one spot to the other. Interesting things in regards to structure. And to bring it back, Kevin, what I would tell you to do is read this study. Realize that we don't have this in the shoulder. At least I haven't found it. We don't have this in the ankle unless somebody's published it. I don't know what it is. We don't have this in the hip unless somebody's published it and I haven't found it. We don't have this information because no one else and nobody's validated this study as far as I know, because it's kind of intense, right? So this is kind of the best thing we have in regards to trying to help someone diagnose, what's going on inside of a knee. And you can take this information and use it to your advantage. Now, for everybody else listening, especially those that are not clinicians, this is one of those interesting things where just because you have knee pain doesn't mean that the injury is substantial. It means that there's enough, whatever going on in the knee that there's pain that's being produced, but it doesn't necessarily tell you that it's a substantial, large problem. What it tells you is that there's something that's going on that probably needs to be addressed and to understand what structure we're talking about. And again, the main point I would like to make out of this podcast, answering Melanie's question and Kevin's question is, again, if you want your knee pain to go away, well, we can get it to go away, right? I tell my students don't like it when I talk to them about this, but I don't know if they don't like it, but I always say it's a educational point. And that is this: we can get somebody's knee pain to go away probably within 12 hours, if not 2 to 3 hours, depending on what type it is. It's pretty simple. Put it in a brace, don't move it, don't weight bear on it, and the likelihood is the pain levels will drop. And everyone's like, well, that's great, but I can't walk on it. I can't bend it. I can't do anything. I'm non-weight bearing. This is terrible. And I go, yeah, well, good thing we're not just treating pain then, right? Because that would be the best treatment. What we're trying to do is get you back to whatever it is you want to do in regards to sport or activity. So you need to understand that, and again, bringing this all back in, if we know the structure that's involved in regards to the knee and what's painful, okay, then we'll be able to organize a plan that will get you out of pain fast and build you up to be able to return to whatever it is that you want to do. So I get this question all the time. I have knee pain. What's the first thing I should do for my knee pain? I first and foremost tell everybody, if your pain levels are above a 4, so 4 or above, I should say 4 or above, your entire job at that point is to get your pain levels below that 4, 3 or lower. And the main reason is because anything higher is potentially increasing damage in the knee. And we don't want that. We want it, whatever's happened in the knee, we want it to settle. We don't want to increase damage. We don't want to push it harder and create more damage. But typically, and I take this from this study as well as a few other studies, okay, that talk about pain levels and where certain damages occur, like at what point is pain an indication of damage. And what they found in some of these studies, and not in all the joints and tissues, is that 4 or above has been associated with higher levels of damage, and sharp, stabby, lightning type pain is more associated with damage, although those are more tendon studies than anything else. But whatever, that's what I'm talking about. So first and foremost, you have knee pain. Is the pain less than a 3 or less than a 4, 3 or less? If it's not, your entire job is to get it to a 3 or less. You do whatever you got to do with that. I will tell first and foremost to everybody, I do not ice this. Everyone tells me, well, I'm going to go put ice on it. It'll drop my pain level below a 4. That's what you want. I go, yeah, but then what happens is you take the ice off and try to move again. And now we got to fight a bunch of other stuff that's going on. Heat does fine with this. Yeah, but what if I have swelling? I know it. I can hear it every time. It's like the same conversation I have every time. What if I have swelling? I tell everybody the number one way to get rid of swelling is not ice. The number one way to get rid of swelling is movement. Yeah, heat may increase the swelling in the area, but it typically only increases it, and it's very rare that it does, based on the research I've read. And it happens more if you don't move. Okay. But again, if your entire problem is that your pain levels are too high, just get the pain levels low. And then you need to start moving it. And you can use heat if you want to. You can use Tylenol for pain. I don't really typically, I can't prescribe medications. I've never prescribed medications, but people always ask me like anti-inflammatories or Tylenol. I go, I don't know, whatever one works better for right now. There's a time where I tell them like, sometimes you want inflammation and sometimes you don't. But so the first and foremost is get pain levels down. The second part is we want to facilitate 3 or less on a pain scale of movement. That's going to allow things to start getting better. If movement increases pain up and over that 3, now we're talking about getting a rehab specialist to get figured out what structure we're dealing with, so that we can then give you a very specific plan to get the pain levels down, but also start moving again so that we can get you on the path to improvement. So these are great questions. It's kind of fun to every once in a while get a clinical question from a rehab specialist, and then also from an athlete in the community. And these things can be pretty tough. And the knee can be a tricky thing, like I've already said. But I think it's important everybody notes that if you have knee pain, get out of pain, get that pain below a 4, so a 3 or less. And the next part is the sooner you can get the structure identified that's the problem, that's had the damage or has the injury, the sooner you can identify that, the sooner you're going to be able to be on the mend and start progressing back into whatever activity it is. And yes, it's a lot easier if you just go to a rehab specialist and have them identify that structure and give you that plan. And a lot of people have asked me, well, how would I do that on my own? And I say, well, that's a tough thing to do. And the two things I tell everybody, and I've already said it again, and I apologize for repeating myself, but I know I get this question all the time. It's like, well, okay, but what would I do if I don't go to rehab specialist? And my answer is always the same. Well, get the pain levels below a 4, so a 3 or less, and then you got to be able to move your knee. You got to be able to straighten it all the way and bend it all the way. Maybe not all at once, but start doing those two things, and keep the pain levels low. If you can do that, and then the third would be walk on it, then there may be a chance where you just kind of don't do anything and the pain will get better. Although I will tell you, if you're an athlete, this is not a good plan. You need to get it identified because there's probably a reason it happened. If you got drilled in the side of the knee because you're playing football or lacrosse or something like that, that may be the reason why it hurts, but that's also the main reason why you should get it looked at so that you can understand if the damage was just short term or if it's something that's going to work its way into long term and whether you should get it addressed. So just remember, everybody, especially my clinicians that are listening out there, structure dictates function and function influences structure. If you understand that, and even if you don't believe it, but if you understand that and then use that to your advantage, you're likely going to be finding ways to get out of knee pain sooner than later. So hey, everybody, I appreciate you listening to the podcast today. A little bit more of a geek nerd episode today, went a little to the weeds and some of the research. Not something I do very often, but we did have a clinician that had asked some questions, and sometimes I think it's fun some people like to nerd out. So if you have questions for the podcast, please reach out. You can go to the website. You can click the link on whatever podcast server you're listening to this on. If you're on YouTube, there's a link on YouTube as well. Please rate and review the podcast on whatever you're watching. That helps us get in front of more people. It also helps us to be able to know and identify what's good and bad about the podcast, maybe things that you would want to see change, maybe more things that you like. And please give us feedback. We do take feedback seriously, so please give that to us, and we appreciate it for those listening. Tell your friends, and we'll catch you next time. Thanks. Hey everybody, I just want to say thank you for listening to the Athletic Potential Podcast. If you do have questions for the podcast, please visit the website, www.athletic-potential.com/podcast. You'll find a button there to ask your question. Please input your information and your question, and we will answer any and all questions we get. And thank you again for listening. If you do get a chance, please rate and review the podcast. And until next time, thanks.